Intraadrenal corticotropin in bilateral macronodular adrenal hyperplasia. Background. Bilateral macronodular adrenal hyperplasia is a rare cause of primary adrenal Cushing syndrome. In this form of hyperplasia, hypersecretion of cortisol suppresses the release of corticotropin by pituitary corticotropins, which result in low plasma corticotropin levels. Thus, the disease has been termed corticotropin independent macronodular adrenal hyperplasia. What is a congenital adrenal hyperplasia?
Alright, so you're wearing a pretty necklace, and you take a little pill 3 times a day. But why do you actually do that? You have to do this because your adrenal glands are sick. Your adrenal glands are inside your body. Look, there they are. Usually, they make very important things for your body that give you energy. But because your adrenal glands are sick, you don't make any of those important things anymore. That's why we put those important things into a little pill, so you get all the energy you need to go out and play. But sometimes, something really exciting happens, and you get butterflies in your stomach. You know, your birthday is coming up, you're going on a holiday, or maybe you have a fever. Then your body needs a lot more energy, and you have to take extra pills. Because if you don't, you get nauseous, dizzy, and you could get very sick. And you don't want that, of course. And your necklace, you always have to wear it, so that everyone knows your adrenal glands are sick. And if something goes wrong when your mummy and daddy aren't around, other people also know that you need more of those little pills.
Cushing syndrome. Chronic excess of glucocorticoids may lead to a constellation of symptoms that include central obesity and arterial hypertension, termed Cushing syndrome, which is associated with increased mortality. Cushing syndrome.
Parents are concerned about the body making extra steroids, and a term is called Cushiongoid or Cushing's disease. What is that?
How about many times people come to me and are concerned that their child may be gaining weight because they may have a condition where their body is producing too much cortisol. Cortisol is produced in a triangular-shaped gland called the adrenal gland, and it's important in its life-saving mechanism of preventing stress from affecting the body. This cortisol is produced in very, very discrete amounts by the adrenal gland under a very sophisticated method of control. It is exceedingly rare to have a condition where the body makes excess cortisol, and one of the easiest ways that a primary care doctor can make sure that that's not happening is to ensure that the child's growth is normal. Should the child be growing abnormally, that means not growing tall enough, and certainly that could be a condition where excess cortisol is made. However, rarely there is a condition where excess cortisol is being made, and a child would seem to be gaining weight out of proportion to what they should be, and at the same time not growing. In this situation, it's oftentimes found a tumor in the adrenal gland or a tumor in the brain causing the adrenal gland to make too much cortisol. And this is best treated through a surgical approach and consultation with a surgeon.
Among patients with primary hypersecretion of adrenal cortisol, bilateral macronodular adrenal disease is extremely rare, representing less than 2% of all cases of Cushing syndrome. Hypersecretion of cortisol by the enlarged adrenal glands suppresses the release of corticotropin by the anterior pituitary, leading to low plasma levels of corticotropin. For these reasons, the disease has also been called corticotropin independent macronodular adrenal hyperplasia. Pathophysiology of corticotropin-independent macronodular adrenal hyperplasia. The persistence of cortisol hypersecretion despite suppressed plasma corticotropin levels was considered to be the result of an autonomous process. These aberrant receptors include a topic receptor for glucose-dependent insulinotropic peptide, luteinizing hormone, and catecholamines, and abnormally active ectopic receptors such as the vasopressin type 1 and serotonin type 4 receptors.
Good mnemonic for congenital adrenal hyperplasia. So basically we know that there are three main enzymes that USMLE might ask you: 21 hydroxylase, 17 alpha hydroxylase, or 11 beta hydroxylase deficiencies, right? So to answer the questions, just remember this, that if you write A for aldosterone and T for testosterone, just write down the numbers like 21, 17, and 11. And the trick is that whichever letter has 1 underneath increases. So 21 will have increased testosterone and lower aldosterone. 17 will have higher aldosterone and lower testosterone. And 11 will have both of them high. So that will actually help you answer most of the questions. Say testosterone is high, so you're going to see virilization of female infants. If aldosterone is high, you're going to see hypertension because of increased reabsorption of sodium, and increased excretion of potassium will also give you hypokalemia. So that will help you answer, I would say, at least 90% of the questions.
Diagnosis of Cushing's syndrome. This is based on standard biologic criteria including increases in 24 hours urinary cortisol excretion, abolition of the relationship between the circadian rhythm and level of plasma cortisol, lack of cortisol suppression after the administration of dexamethasone, decreased basal levels of plasma corticotropin. In vitro studies, synthesis and secretion of corticotropin in the hyperplastic adrenal glands were investigated with the use RT-PCR assays and immunohistochemical analysis, and by means of cells culture experiments and incubate adrenal explants. In patients with macronodular adrenal hyperplasia, over hypercorticolemia, and insuppressed plasma corticotropin levels, corticotropin secretion by the adrenal glands should be considered and explored by sampling the adrenal veins rather than by catheterizing the inferior petrosal sinus. And the conclusion: in patients with bilateral macronodular adrenal hyperplasia and Cushing's syndrome, cortisol production is controlled both by aberrant membrane receptors and by corticotropin that is produced within the adrenocortical tissue, which appears to act as a local amplifier of the action of the receptors. From a pathophysiological point of view, the term corticotropin independent, which has been used to designate case of bilateral adrenal macronodular hyperplasia with hypercortisolism and low plasma corticotropin levels, appears to be inappropriate. Thank you.